Good morning, everybody. My name is Andreas Wittmer from the University of Basel, and it's a very privilege to introduce Andreas Voss. It's exactly 9:30 atomic watch, and I hope that our speaker will follow the timeline as well. Andreas Voss is chair of at the University of Groningen. He has a long history of infection control over decades, so it's very nice and privileged to introduce him, and he has the talent to really mix the facts, which are always up to date, with some fun slides, so that will help you to remember his facts. And he's from Europe, not from the US, so I don't think that we will hear some fake news, but I'm looking forward. Where is infection control going? Andreas Voss, thank you very much for participating.
Thank you, Andreas Senior, for introducing me. I just want to say I have nothing, there's nothing to disclaim in my case. And the title is From the Past to the Future. So I wanted to start out with the past. And if you look into the past, I really went back. So I went back to Hippocrates and nil nocere, with other words, do no harm. More importantly, Hippocrates was also the one who said prevention is better than cure. So these principles we still live on started really early. But let's jump forward a little bit, and then we jump into Florence Nightingale. And she again said the hospital should do the sick no harm, and she was a great epidemiologist, and more importantly, she was the one to introduce professional rather than untrained nurses to hospitals, applied her knowledge to hospital design, and in her book of 1860, she describes the essentials for health and recovery, namely pure air, pure water, efficient drainage, cleanness, and light. Things we still drill on. But let's jump again way much forward, I would say, to the study I believe still is the best in infection control. This is Bob Haley. He was heading the SENIC project, and the SENIC project, the data were all from 1974, but it was published only in 1980. But this is the only proof we have that the implementation of infection control and prevention programs lowers the rate of nosocomial infections, because they were between non-existing and existing, a study we couldn't do again, I would say. So let's away from the legends to the non-famous, AKA my personal experience, and we jump a little bit forward to 1986, 1988. This is me when I was still good looking, and this was at the beginning of my time in infection control, and everyone was, when will clinical hygiene, see, I'm already falling over here, when will clinical hygiene be taken serious? And at that point, I had no idea that it certainly would not be in the next 35 years. So we'll see, I'm still waiting for the point when that is the case. And at that time, it was all about the great debate of horizontal versus vertical, or universal versus infection-specific. So do we prevent all, or do we go for specific isolation measures for specific organisms or diseases? And the fun part is, even in the workshop we had at the beginning of this meeting, this discussion was still coming up, and it's still ongoing, which is kind of amazing. Whereas I think that with hand hygiene, disinfection methods, antimicrobial surfaces, checklist, integration of infection control into clinical SOPs, and culture change, it's all horizontal. But my true opinion is that any good infection control program is combining horizontal and vertical strategies, and should do so now and in the future. Thus, what is in our way to a healthcare-associated infection-free future? What do we have to climb over? What do we need to do? The problem is that we all know that compliance with IPC measures remains low, way too low. I mean, with the exception of NHS, who are reporting fake news every time they talk about their hand hygiene, we know it's not really that good. So hand hygiene should be a reflex, but we are far from it. It's certainly not a reflex as it should be for a long, long time. And then going back to the past, I think that this man would certainly have a question about it, and Ignaz probably would say, what's the ... is going on? I mean, it's more than 175 years ago that he demonstrated the importance of hand disinfections, and we were still not able to implement it in the full way it should have been implemented. And that's probably due to the fact that even nurses are just healthcare workers are just human beings. And we all know how human beings react. And many of you have seen this slide 20,000 times, but I still use it. Do not climb, play on and around the pipe. This is just human nature. Probably the one person on the left is the secretary, the person on the right is the CEO of the hospital, and all the nurses and doctors do what they're not supposed to do. And then there's hope. There are new healthcare workers, and now things are coming well. No, within no time they're on the pipe too, so just forget about it. So this is human nature, and will continue like that. And then there is the most dangerous microorganism or macroorganism, the multi-resistant healthcare worker. So it's resistant to good advice, allergic to professional guidelines, non-compliant with IC measures, blind to healthcare-associated infections, and has completely different priorities. Yes, unfortunately, that is how we know a lot of our healthcare workers. And then there is the culture problem of how we are perceived by clinical colleagues in the hospital or other areas. So we're usually seen as a sheriff, policing them around all day long, telling them what to do. And yes, it's not this kind of sheriff, it's this kind of sheriff they see in us. So this is obviously how we are perceived by a lot of our clinical colleagues. So the fun fact actually, and I've included a few fun facts, a healthcare worker who is 80% compliant with IPC rules is a hero. If you do it in my hospital, you get free parking. A pilot who is 80% compliant is without a job. So how is that? Are there more people dying from plane accidents or from healthcare-associated infections? The answer is very clear, way more from healthcare-associated infections. So it's really time for a culture change, which we just haven't achieved over all those years yet. Then let's jump to the built environment. And this could be NHS today, but it's not. Most of us improved. It's not a la Nightingale anymore, in most countries at least. But I wanted to point out two facts, namely about the proportion of single rooms we need or not need, and water as a source of infections. The proportion, how many single-bedded do we need? It's a discussion for as long as I'm working in infection control, and it's always coming up again. And the good thing is, obviously, when you have all single rooms, this is a hospital in the Netherlands which has single rooms only, which was great during COVID because you have absolutely no problem to cohort your patients, but is it really needed? And the role of single rooms as part of MDRO isolation is in partly still discussed. This is a great study from Marjolein Kleitmans, who looked into that and found out that the isolation strategy of contact precaution in a multi-bedded rooms was non-inferior to strategy of contact precaution in a single-bedded room for the prevention of ESBL transmission. Don't be wrong, we still use single rooms certainly for like carbapenem-resistant microorganisms, but there is still a discussion ongoing. And what we frequently miss and should do better in the future is the perspective of other people out of our own box. If you talk to some people who work in psychology, who work in architecture and others, you will find out that there are tons of studies showing you that some patients want a 4-bedded room or a 2-bedded room. They don't want to be isolated in a single-bedded room. And how to create your single-bedded room, it can be from Feng Shui to evidence-based design to golden ratio. There are different ways. So we need to be way better in cooperating with those colleagues from outside our specialty. And not only medical specialty, but going to different ones. And then there's water as a source of trouble. And I mean, we all know that our hospital sinks and drains can accumulate strains with any kind of resistant genes, whether it's CPE or any other. It's well known. It's kind of a disaster waiting, and like you can see for those who were in the workshop, Martin Kierman and I, we have thinking the same way. We use artificial intelligence, which is the only one I have left, to create anything we need. So water is really a major problem. And what I really hate about this is, when do we finally learn from the past? From the very first moment I stepped onto the Dutch floor and became a Dutchman, I'm publishing water outbreaks more or less every second year. And it's always the same sources, and we seem not to be able to learn. And I really need to change something about that, so it's time. And in Nijmegen, Joost Hopman and colleagues tried to do that, and they said, let's go completely waterless to get rid of the problems. And they were clearly showing that without the things, the problems were solved. So that's a great thing. I do not believe that you have to go completely water-free, but you have, as a minimum, make sure that there's no water source close to your patients. We're talking about 2 meters, or a chance of splashes onto pathogen-free material you intend to use with your patients. So you really have to do something about that to, at one point at least in the future, stop outbreaks related to water. Next topic would be about cleaning, and this is not yes we can, but can we do it? I think it's a far bigger question, and yes we cannot would probably be the right answer at the present time. There are still many problems, from who is doing what, vacant responsibilities. Due to the fact that we have a lot of flex staff, that we try to combine staff from different units, we absolutely ensure that no one knows what to clean and what is his or her responsibility. The training of the health of the cleaners is not good enough, their PR is ridiculous, and their payment is even worse. How can we expect them to do a good cleaning? The quality checks at present are mainly visible. They do not use ATP or any other method to get a quantitative idea about what is actually going on. And the place of tech, yes, we should need it, but to a certain degree, even that is still open. Talking about technology, I like to cite Bob Weinstein, a good friend from Chicago. Given the choice of improving technology or improving human behavior, technology is the better choice. At least you make a chance. So yes, and if you go into technology, you all know this automated room decontamination devices. And if you, whether it's hydrogen peroxide or it's ultraviolet UVC light, we know they both work. HPV has a higher log reduction, so it's a better killing, but it's a disaster to actually use in your rooms, I would say, to prepare them. So UVC might be more practical. Still, all these devices can only help once the patient is out of the room. So I say both of these types, in my opinion, still are completely add-ons. And the good studies to show that they can replace some of the normal cleaning are in part missing. There were a few now. So there is more than UVC. There obviously is far UVC, and we know there have been some studies on it, but mainly in vitro and in animal models, and there is no long-term safety studies in clinical settings. This is a light source you can use for disinfection, and people can still walk in the room. They're not allowed to stay in the room, but you could walk in and have short exposures. So we need to look more at that. And there even are visible light solutions. There's a 405 nanometer solution, a lamp that you can continuously leave on. It's called blue light, but the technology is already 20 years old, and there is one newer study with SARS-CoV-2, but there are any good studies whatsoever. So I really wonder how good this technology will be. But we might see other visible light solutions next to UVC and far UVC. And then there could be a paradigm shift. So this is from a paper which Andreas Wittmer actually started out and brought the people together, and you see some of them here in the room. But we look into is the probiotic cleaners, is that the paradigm shift? My personal conclusion, There's not enough data to say it's a paradigm shift, but there's certainly enough data to say that there is probably a sustainable alternative to chemical disinfectants. So when you ever had the idea, I'm using it somewhere where I'm not sure if I should use it, then you can certainly use probiotics as a good alternative. At least you are sustainable. And then there's, of course, when is Tesla cleaners coming into the healthcare setting? You might think this is far away, but once the Tesla owner has something better to do than supporting the wrong people, he might continue with it. But and look into when are these robots coming? And is it so far away? The right model is actually already in existence, and it is from Tesla, funny enough. We already see robots in any kind of interaction with patients in our hospitals, so this is already ongoing. And when I see those things, it reminds me of something of my early career. So the question to you would be, what do these two have in common except those cute eyes? And I don't know, for those who are a little bit older, they might remember cross-infection between animals and man, possible feline transmission of MRSA in a geriatric ward in the UK where they had a ward cat. And my question is, are those robots the new ward cats we have in the future? Who is taking care of those? I mean, with a cat it was fairly easy. We just banned them from the ward. But what are we going to do with the robots? They will be there. They will be driving from everywhere. They're already bringing the food. They already entertain our patients. And they will be more into real patient care in the future. So it will be a challenge to what do we do with regard to infection control. And I didn't know where to put this slide, but I needed to put it somewhere in there. We always forget about that future diagnostic, namely point-of-care tests, zero-cost diagnostics, that are on your handheld, that will be add-on to your telephone, this kind of test. And then testing can be done everywhere. You have direct action with regard to isolation. You can change your empiric treatment, and it will be a paradigm shift for low and middle income countries. I strongly believe that the future diagnostic will really change also the way we handle infection control. But let's go to the next topic, guidelines. And I couldn't resist but to say IPC guidelines are like American politics. So some people might say they're a bit crazy, but it's also missing a lot of facts, and just we call facts evidence. So unfortunately, we don't have a lot of evidence to really build our guidelines on. And so still sometimes those who scream the loudest has the most influence. And I know we try to do our best to do it differently, but unfortunately that still frequently is the case. And on top of that, we build far too many. I mean, the clinicians don't want to see any more guidelines. We already have way too many. And even worse, and another fun fact, even the professionals working with me look up the guidelines they wrote themselves because they don't know what's written in them. How can we expect that clinicians know what's in them? I have no clue. We produce 36-page guidelines, and then we hope that everyone studies them at night. This is ridiculous. So we won't get there until we really fully integrate our infection control guidelines into the standard operation procedure of a hospital. That is a must, otherwise we can never ensure that clinicians can follow our guidelines. Let's go to something which I would call a unique problem of infection prevention and control. And what is the unique problem? It's another fun fact. If you do your work really well, your institution will have few problems and you will become invisible. You will lose your resources, you will lose your people, because why do we need infection prevention? We are doing so well. Yes, because we are here. You are doing a great job. That's why we don't have trouble. So there's only one good thing. So if you look around a little bit, you always find the infection control can of worms. And that's a great thing, because this will ensure that you have work for now until the far future, for as long as you're happily around. And just to mention a few, occupational health, they go around my hospital and tell anyone that they will get cancer if they disinfect their hand with alcoholic-based hand rub. Because if you swallow ethanol, you obviously have a higher chance of cancer. I don't think that you can wash your hands or disinfect your hands frequently enough, but there are some really bad studies about that. And the fire marshals, already mentioned by others again, but the fire marshals who do not allow hand disinfection in the patient room or close to the patient, which is of course ridiculous because that's where it works. That is the whole idea behind it. Uncleanable reusables, failing technology, and hospital bias, which you might not have thought about. Talking about uncleanable reusables, what do most clinicians know about the safe use and reprocessing of the devices they use on a daily basis? I can tell you nothing, or close to nothing at least. That is something they have no clue about. And how do you clean those things? If I ever get a robot-assisted prostatectomy, which is probably in my near future somewhere as an old man, but if I ever get it, I want to be the first with new robot arms and not number 10, because I have opened those things illegally and I know what's flowing out of it. It's uncleanable. And this is true for many of the minimal invasive surgical instruments. They were made and developed with function in mind, but not with cleaning and disinfection. So we will see more and more of this. This will never, ever stop. And the other neat thing is meet your new autonomous phlebotomist. This is how blood be drawing in the very near future. Those machines are already there. You are all alone. You stick your arm in there. It's kind of held in place, which I already find not very attractive. And then the robot is taking your blood. How do you clean these terrible machines? Who is cleaning the terrible machines? And then personally, as a good Apple user, I would never trust Windows to run these machines. So I don't think, I want a person who is doing it and whom I can observe how and what they're actually doing. But this is our near future. And then there is endoscope reprocessing, which you all know. And this is a typical story. You try to take an endoscope in the morning, a clean one, you take it in your hands, and yes, it's ready to use, but the blood is running out. So instead of just cleaning it up, this colleague actually warned infection control, there might be something wrong with my scope. And how do you achieve that? It's in a hospital where we just had a year ago the most supersonic, newest, best machines there are. And still we created a ghost scope. And was it human error or structural problems because we had too much customized, which we did, which was a problem. And the other thing was unforeseen technical problems. These things are online. So in the night before that scope was cleaned, or better not cleaned, they had an online update, and as of that moment, one channel wasn't cleaned anymore. And no one knew about it. No one knew about the update, no one told us, and then suddenly you have scopes that are not being cleaned fully, while you do believe you have the highest standard possible around. So these kind of surprises will come all the time. And then there is, of course, the spreading of multi-drug resistant organisms. And yeah, Suha, the first, Suha is sitting there. I wanted to point at Kansu. Kansu, the first author of this paper, is here too. And this is different from the normal we-spread multi-drug resistant microorganisms by endoscope. The difference is that this one was fully reprocessed. It was culture negative at all the time, and only because in our setting, all multi-drug resistant organisms, about 1,600 per year, are whole genome sequenced, so we know what's going on. That way, we found the outbreak, we knew there is a cluster, we knew that scope was involved, and you can see it was repeatedly negative with standard screening techniques. And only after destroying the scope, taking it apart, we finally found the Klebsiella that was involved in this cluster. So again, even in the future, you're doing the best, and we still have problems. And obviously, this is one of the reasons why I say we need to apply NGS broadly within IPC to many, many of the organisms, and actually maybe not only the multi-drug resistant ones, because this is most problems we see are due to multi-drug resistant organisms. But it's a fun fact that at least 90% or more are to the susceptible brothers, And so what do we do with all those hidden cases? We really have to do better epidemiology and not only do it with multi-drug resistant ones. We have to look at the process and see what is going on. And then there is a stingy hospital buyer, and you probably all know them. Now, you took a lot of effort and hard work to introduce clippers to prevent surgical site infections. Then there comes a change of management or buyers. Out is the clippers, in is a cheap razor, and up are surgical site infections. And the fun part is, it's a cycle of life, because you find out, you get it back in, it will take you even longer than the first time, and again a new manager comes and has brilliant ideas of reducing costs for the hospital and introduce something. And this is going on with all kinds of things you thought you had well implemented in your hospital. Okay, so in my opinion, it's not a question of if the can of worm opens, but when, and I can tell you it will open all the time in the future to ensure you have enough to do. Let's go to infection control and susceptibility, sustainability. Friend or foe, and it was already mentioned by Margaret in a sense that this terms about is it a friend or is it a foe. The good thing is that at the present time, all our guidelines are based on national, more or less evidence-based measures. They are not perfect, they do have some holes, but they are the best we have. And in the past, we always had discussion with our clinical colleagues about it doesn't work, where is the evidence, I need an RCT, otherwise I don't believe you. And the fun fact is that exactly the same clinical colleagues nowadays, they eagerly jump onto the bandwagon and they continuously slice our measurements. They got rid of part of a bundle we introduced into care. They have no guidelines how to do it. There's hardly any research on the impact they are doing, and they will certainly not tell you about that they are stopping with a certain measurement because of sustainability reasons. So what we need is way better cooperation between the sustainability people in the hospital, because there are many and they are very enthusiastic, and between infection control. So we should do that to avoid that, let's say, little hygiene is like struck out with a ritualistic and wasteful IPC wastewater, which the people believe what we are having. And I believe there are low-hanging fruit that makes it possible to do it. So let's go to AI and infection control, and you can see only problem, it tends to hallucinate its own facts. What should we do? Run it for president. And some countries are actually doing that. But yesterday already, Adrian Ekli showed a nice paper of Brownstein about the advances of artificial intelligence. I just wanted to point it out. It's not that New England paper, but it's a great work from one of the PhDs from Groningen, hanging over here at the side, Geister Nu, who did a scoping review of all artificial intelligence with regard to infectious diseases. So it's a nice poster and hopefully a great publication in the future, and he put in his heart and his soul. So wherever could we use it? AI support for integration of data, so we can have better modeling, prediction, forecasting with regard to public health threats. But it's already in my hospital, AI, ChatGPT is actually integrated in the electronic patient dossier, the hospital information system. So I would hope that we have surveillance of AMR and healthcare-associated infection fully automated in the future. We can simulate outbreaks and identify potential mitigation interventions. We can predict the risk of nosocomial infections and outbreaks, and even AI might suggest interventions. Last but not least, its integration into diagnostics will help to predict infection risk, like depending on genomic features, and we have heard all about that from Adrian already, and it could be used for teaching and auditing by AI, like image and video-based auditing of behavior of our healthcare workers should be working. Or Shop-Align, which is actually an AI tool Heimann Wertheim here developed in Nijmegen with people from his AI department to make sure that guidelines actually, the local guidelines, are in alignment with the national guidelines. So we do need more experts for that. So infection control teams will look different. And I hope that after 6th of January, there's one additional expert to there. There's no sound, which is very unfortunate.
Artificial intelligence, who needs that? I do great infection pre-something, it's great. Just ask.
Yeah. So I do hope that this is the end of this person at least. It's nearly the end of my talk. I have 2 more slides just to round it up. Some of our current problems will be automated and engineered out, while others will just stay around. Still, IPC teams need to expand their physical boundaries, so we have to leave the hospital and really work system-wide, and we need different kind of knowledge for all different kind of healthcare settings. We need a new skill set, new type of professionals to support what we actually have to do. And whatever will come, we always will need highly trained, motivated professionals who are able to see what's going wrong, to recognize what's going well, and who are masters in communication with their clinical colleagues. And now you're really at the end. Thank you so much, and thank you to all my officers.